temporization, ligating to central incisor to prevent any space opening. And now I place 2 mini screws in the lateral position. And now, what about the width and the length? In the literature said, the use of sufficiently large mini implants is about 2 mm in diameter, and about 11 to 15 mm, depends on your length, on your case, and avoidance of occlusive interference to the composite that you will help in treatment success, an important factor in terms of stability. After putting the mini implants, just start to build the composite above the mini screws. It's very simple, as you know, and it's more simple than the posterior TATS insertion or infrazygomatic positioning of TATS. Just anesthetize topically, as you know, or a little bit of anesthetic solution, and then insert it perpendicular to the bone. And from the success criteria for me, I start to make a sandblasting for the mini screw, so more adhesion of the composite to the mini screws. And then start to build up. I float the composite first, and then build layer by layer. At the last layer, you can use any celluloid strip, legal surface or legal part, to just contour the lateral to be like the lateral incisor easily. So it's a simple option. And finally, I finished the 2 lateral incisors as temporary option with 2 mini screws with composite attached to that, and helped me in papilla formation as well. So it's completely relieved, and the mini screw shouldn't touch the lower incisor for more success rate. So now it's time to remove the bases and go for retainers. But what about the longevity and also integration? In some literature they spoke about that. And buccolingual width. Does the mini screw maintain the buccolingual width that will help us in implant placement or no? We need more literature, so I support it here. Any resident or postgraduate students, it will be a fantastic research for you, okay? To check the longevity and buccolingual width preservation for more literature. Further clinical studies involving 3-dimensional evaluation of bone volume should be performed before and after the use of mini implant supported Pontics. And that was a literature from Roberto Celentini. He showed like semi-permanent replacement of missing maxillary lateral incisors by mini implant retained Pontic. But Roberto started to put the mini implant a little bit into the palate, not in the lateral space. Okay? And the conclusion of his research was a method of semi-permanent replacement of missing lateral incisor has been described, and maintenance over 5 years has been demonstrated. He welded a small piece of stainless steel arch wire to the mini implant and built the lateral above that piece of stainless steel arch wire. Composite molding was placed on the stainless steel wire segment, extending from a lingually placed tag with bracket-like head. So, let's start to implement that challenges. Here we have a case with large midline diastema, and the canine start to erupt into the lateral space. I advise the patient to follow up after 1 year. After 1 year, she came, and the upper canines and premolars completely erupted in the upper arch. Now I start to make space opening. The patient was having a thick legal frenum, okay, about 5 mm between 2 central incisors, and also we have posterior spaces. And that's the occlusion of the patient. We have a class 1 molar relation in both sides, class 2 canine relation. So my plan was to open space for the lateral incisor and to make maximum bodily movement for the roots as I can, so I can place the implant later on. So that's the smile of that amazing girl. I start to move the central, so I flip the central brackets, and the canine brackets a little bit angulated to change the root of the canine during my treatment. And now start to close the spaces with power arms, and then do continuous space closure. After about 1 mm space between two central incisors, I start to do frenectomy and to continue space closure during that time. So now, frenum removal, continue space closure, and open the space completely into the lateral space. Now here, I start to put a temporary pontic by acrylic tooth attached to the arch wire. It's very, very simple. And don't forget that figure 8 tie to prevent the patient from rotating the acrylic tooth around the arch wire. Okay? It's very, very simple. And after space completely formed and occlusion settling in the posterior segment, just wait the patient to put implants. And check before removing the braces the angulation of the central and canine. Because at the past, I was referring the patient for implantologist. So I don't care about the implant. But now I'm the one who will put the implant. So I'm caring about the finishing, the roots of the central, the roots of the canine before removing the braces. And check also the backlingual width, because it's challenging for the implantologist or the surgeon. I now have enough bone backlingually and no need for phase 1 or buccal augmentation of the bone. How many millimeter? We opened about 6 millimeter for the lateral incisor. And we need to use small implants. So it's about 3 millimeter or 3.3 millimeter, okay? So you have 1.5 millimeter mesially and distally around the implant for osseointegration and to can build the crown of the implant. So now 6 millimeter incisally and the implant around 3 millimeter diameter, 1.5 millimeter mesial and 1.5 millimeter distal. What's the ideal time to place the implant? It's an important issue. There is many literature spoke about that topic, and the most predictable method to monitor changes resulting from craniofacial growth is through total imposition of sequential cephalometric X-ray. It's around 6 months to 1 year, but we have the risk of X-rays, okay? So now they advise that in general, the average age of growth completion is about 17 years for females and 21 years for males. Thus, implant placement could happen after this age. Nevertheless, these data represent a statistical average and are not suitable for any given patient. So just wait above 17 or above 18 and you can go for implant. Determining the sensation of vertical growth by Kokich, and the conclusion was the growth of the facial skeleton continues after puberty, but the amount of growth decreases steadily and after the second decade of life seems to be clinically insignificant. So now it's time to place implant bilaterally 3 millimeter and just go for osseointegration time and then fix the crowns. So I was lucky that I started the braces around 16 to 17 years old, and after 2 years I finished my orthodontic treatment, so I can put the implant during the orthodontic treatment phase. In some patients, if you start the treatment earlier, like 12 years, so you will have more time between the implant and the braces removal. So more risk for buckling with resorption of the bone. So now I placed 2 mini implants. I don't know if you are interested in putting implants or no, or any one of you have double qualification, ortho and implant. Okay, just prepare the case for television. So now we have central incisor, 2 lateral incisors, and we need to do a little bit gingivectomy for the canine and first premolar. So just use this gauge to just predict the mesodistal width with incisor-gingival length of the canine and go for gingivectomy for the canine and first premolar. And finally, the gingival level is high, low, high for the central, lateral, and canine with normal overbite, normal overjet, and angulation of the central incisor. And that's the smiling profile photo and profile photo for the patient before and after. That's no changes in the lip position for the E-line relation with the lips and 45 degrees smiling for the patient. And that's the changes from starting the treatment till finish the treatment. But the problem is, it's long treatment time. Seems like I changed the clinic decoration about 3 times during this treatment. And at the end of treatment, I changed the location of my clinic to another place, just to stop following up the patient. Because you are a starter treatment, and you can see the changes that happen in the patient during this age. Okay, so the harder you work for something, the better you will feel when you achieve it. We have another challenge. The space opening mostly may be indicated, it's like guides, but not in all cases. If you have multiple missing teeth, laterals, premolars, molars, and if you have reversed convergence due to retrocline upper incisors, so we will think about space opening. So most of the space will be used to protrude the upper. Let's go for this case. The patient came to the clinic just complaining about 1 millimeter midline diastema. And as you see here, you have a little bit whiter color in the lateral and the canine. So it's not permanent. It's a primary laterals and primary canines. And the patient only complaining about 1 millimeter diastema and crowding in the lower arch. Class 1 molar relation, class 1 premolar and canine. So now, in the occlusive photo for the patient, we have two bulges in the back that indicating the canine position. And after requesting panoramic X-ray, the canine is pushing the retained piece, so more resorption happens for retained piece, and it's a little bit toward the midline. And as you can see here, the mesodistal width of both canines is a little bit larger, which is indication for impaction palatally. And then the literature spoke about, if you have retained C with deep bite, okay, and any anomaly of the lateral, either missing or big shape, you have a palatally impacted canine. So now we have retained B's, retained C's, and canine. So my plan to extract C's and maintain the primary lateral in place and to retract the canine in the ideal position. After CBCT requesting from the patient, it's palatally located with a small amount of bone covering. So the first phase will be canine traction, how to deal with impaction treatment. And the second phase, after 18 years old for the patient, I will go for extracting the primary piece and putting the implants. So that's the smiling for the patient. The problem list was remaining upper B's and C's, impacted upper both canines, and missing upper laterals and crowding in the lower arch. So just start to level and align. And the plan was just to go for open exposure for the canine, not closed. I choose open eruption technique. And then after open eruption technique, I will use double brackets. It's like, not double brackets, double wire. It's like baby back mechanics, as you know. And after retracting the canine, I will not bond any brackets on the lateral. So just expose the canine and only eyelids and the gradual retraction of the permanent canine with C's space. And after that, I will ready for the implant placement and extraction of B's. So step by step, exposure, open eruption mechanics. After leveling and aligning, it's time to extract remaining C's and to make a server chain to track the canine in its position. And it moves palatally, and then gingivectomy, and to bond braces into the canine, a little bit extrusion needed, and rotation. So I return it back to smaller arch wire to engage the bracket completely after eyelid debonding, and now it reached the ideal position. Before removal of the braces, you should go for panoramic X-ray to check the angulation. And I have a filler cases, like you can see here. You can focus on the problem here. I have enough space incisally, but I don't have enough space apically. And if I will go for implant in that case, the implant will hit the canine root or the central incisor root. So now, how can I correct the angulation of the central incisors and the angulation of the canine so I can put implant? There is wrong angulation for the central and not enough space for the implant apically. Let's revise our three options: the pins or rebonding and make switch of the brackets, or to use power arm, but I can't use it now. So I went for the best option for me, just rebond the right and left switch, okay? And to rebond also canines and little bit angulation of the canine bracket to correct the angulation of the canine. And of course, I went back to smaller arch wire so I can engage. But now during leveling and alignment, what will happen is diastema formation again. Okay? So to prevent the space from reopening, you can make a ligation or ligation for the two central incisors. The less is more. It's too simple, but just don't forget to make a ligation wire that ligating the two central incisors. So now, the force will go directly from the crown to the roots. So no reopening space incisal, and just the root will move. After changing the arch wire again, 3 months later, it seems fine now. We have enough space incisal and also enough space apically. So it's time to go for implant placement, and that before correction of the root angulation, and that after correction of the angulation of the central incisor and canines. So in literature, it said that you consider preserving the alveolar wall by retaining the primary teeth for future placement of implants once growth has ceased. So I left the retained piece in its place till implant time. And after 10 years old, you can go for just extraction of the retained primary lateral, and to cut the remaining piece of the root, and to put the crowns back into the VFR retainer, so the patient can use the retainer during post-integration phase. After finishing the case, 3 months later, after integration, you can go for prosthetic crown placement. Okay. So benefits of space opening in literature, they said that faster than space closure, of course, advances both functionally and occlusally, favoring good intercuspation in the buccal segments, class 1 relation, maintains or creates canine guidance, okay, as canine in its place. Missing upper incisor, retrospective study of orthodontic space closure versus implant, the conclusion was orthodontic space closure implant of missing maxillary incisor produced similar, well-accepted static results. None of the treatments impaired TMD function problems. And showed better periodontal health in comparison with implant. Space closure patients also show better periodontal health in comparison with implant patients. It has been found that during orthodontic space opening, a decrease in vestibular oral width by up to 15%. Like I faced in that case. She was like 12 years female patient, came to my practice with bilateral missing laterals, not only laterals. I have also here missing second molars in the upper arch and in the lower left side. So after I finished my orthodontic treatment, I wait like 6 years to put the implant. And while to go for CBCT for the ridge before placing the implant, I was astonished that I have only 2 mm in the right side, maculingual, and 1 mm for the left side. And now it's time to go for, not for bridge.